So cervical cancer screening, we know, is a huge terminology, and each and every topic which I'm going to talk about the test, it's a one day topic. We can say one day discussion whole we can do on a one subject. So to bring all together in a 45-minute session was a very complicated thing, and from 2 3 days I'm continuously making it simple, because I know we have varied health professional in this forum which are going to hear about cervical cancer screening. We are having paramedics, medics, nursing staff, everything. So I think that they all should know about the cervical cancer screening, and those are the people of frontliners. We are the specialists, so sometimes we come in a third tier of reference, but you are the frontliners and you should be aware of cervical cancer screening. My introduction is already being given. I have more than 25 years experience in gynae oncology, and I have done the first pilot study of HPV self-test in Gujarat. I was an ex-associate professor in GCRI, which is a tertiary cancer center in the western part of India in Gujarat, and now I'm in private practice. So we all know cervical cancer is a major health problem. 80% of gynec cancers in the woman are cervical cancer. In developing country, it is a leading cause of death in women between the age of 40 to 60 years. And what is happening at this uh, age group, that if a woman dies of cervical cancer, she has to look into two generations, that is her, what we can say, children's, and she has elderly parents. And to lose a woman, there is a big social imbalance which has never been calculated. We only calculate a person died, but what is happening to the family, what is happening to the generation, a mother is lost, a daughter is lost. This is a big, what we can say, a brunt of cervical cancer, and which is happening, and that is a major issue. And 80% are diagnosed in stage 3. Now you see on the left side, this is a normal cervix and this is a cancerous growth. This is also we consider early, but women come in a very later stage. If you see worldwide, there are 5 lakh cases occurring, and out of that 1.2 lakh cases occurring in India. Death are 2.5, 50% die because they come in advanced cervical cancer. In India, we have nearly 70,000 deaths. So every 9 minutes, a woman dies of cervical cancer. It is the commonest cancer in India, second most commonest cancer, and very common cause of death because of this cancer. 70,000 deaths occurring every yearly. Imagine my lecture will be over by that time. 3 women will be dead because of the cervical cancer, and this is a big tragedy, a very pathetic part of our country. Now, if you look into the global burden, the dark areas are the area where is the incidence of cervical cancer is very high. We come in the orange zone, and Africa, the lower part of South America, which are underdeveloping, we have very high incidence of cervical cancer and the mortality rate, death rate due to cervical cancer. See, this is 2020 data, the global burden, 6 lakh new cases detected, and 90% and in low and middle income countries, and nearly 50% die. The cancer death of cervical cancer is more than the childbirth, but still there is not a big noise for it, not awareness about it, because it's a slow death. It is a slow occurring cancer which has been neglected for years to years together, and ultimately women come and die, and it has never been highlighted. Cervical cancer is a rare outcome from a very small common infection which we know is an HPV infection. HPV is an human papilloma virus. The persistent infection will slowly over the years it develops cervical cancer. The understanding that HPV infection, especially the high-risk type oncogenic, is a necessary cause of cervical cancer led to the development of HPV test and change in screening pedigree of cervical cancer. We know what we're using age old was pap smear, and it is now been replaced by HPV test, and this all credit goes to Mr. Harold Hussein, who is a no, we can say he discovered that human papilloma virus is causing cervical cancer. He received a Nobel Prize in Medicine and Physiology in 2008, and we are proud for him, and it was his discovery which led to the change in the pedigree. HPV is also celebrated as an International HPV Day, which is on 4th March, and the theme is No Less Worry. Now, why such theme was made? Over the last years, the campaign of HPV awareness used that one less worry to communicate, because the uncertainty and the turbulent world we are living today, and what all the personal problems we have today, but HPV is one thing we can tackle because it is a virus which can be prevented. We have tools to diagnose it and treat it. Hence, we have one less worry. Though the HPV is a cause of many cancers in males and females. Now, coming to the details of HPV, I have to talk about HPV. Then only you will know the basis of test, and then you can understand much better. It's a cause and it's a base of cervical cancer. Many cancers, in fact, HPV is human papilloma virus. There are 150 types. 14 types are oncogenic, means they cause cancers. They cause 6 types of cancers in men and women. Cancers of cervix, vulva, vagina, penis, anus, and oropharynx. So if you see, out of 150, 100 are genital, they which are in the private part in both men and women. High risk are 14 types, 16 and 18. The each and every HPV virus, they are designated, given particular number. So 16 and 18 are considered high risk, which cause around all cervical cancer. Other high risk, there are total 14 high risk oncogenic type. So other 12 viruses are put in other groups, and low risk are 6 and 11, which are responsible for the warts. So if you see the association of cervical cancer, 16, 18, 31, 45 are responsible for 80% of cervical cancer. 16 alone is responsible for 50, and others are there, but the contribution is less for developing cervical cancer. So you see, 16 and 18 HPV virus is responsible for 80% cervical cancer, vaginal and oral cancer in women, and 6 and 11 are responsible for genital warts. Now, why these numbers are important? Because the recent vaccines are based on this quadrivalent or nanovalent, and yes, this is the reason why these numbers are important to us. We have to remember that 16 and 18 are very high risk and they are responsible for cervical cancer. So if you see global burden of HPV related cancers, 6 million cases, and from the oropharynx to the genital area, both in male and female, are caused by HPV. And if a woman is HPV positive, and if she has a vaginal delivery, the baby will swallow the vaginal fluid and the baby will develop respiratory, what we can say, laryngeal papillomatosis. That is a very bad type of infection. So these are all be prevented by doing a simple HPV test and treating yourself, and by vaccination. So 5% of all cancer detected worldwide are due to HPV. So HPV is responsible only not cancer but HPV related disease from various cancers, from the squamous epithelium to pre-cancer conditions and genital warts. Now if you see the world burden of HPV related disease, cervical cancer more than 6 lakhs, vulval, anal warts 30 million cases, abnormal pap smear, the HPV is causing abnormal cervical pre-cancerous condition, 10 million cases. Imagine if all these women are not treated, they are definitely going to undevelop something or later in their life. Now coming to HPV virus, again we have to know the details because most of the HPV tests recent are depend on this proteins of the virus. The virus is a circular virus and it has the capsid protein L1, L2 and E6 and E7. You have to remember E6, E7 are the enemies and they are responsible for cancer. So this is the virus and these are the different types of protein. When the virus is replicating in the cells of the body, it excrete L1, L2, what we can say, proteins, and that is expressed, and in later when they are expelled from the surface to the vagina, it expresses E1, E6 and E7 proteins. Now, this is the cycle of HPV. What is happening? This HPV infection will not affect the normal cervix or intact cervix. Now, cervix is what a cervix is. It is the entrance of the uterus, which is called Bachedani ka mukh. that is cervix. And the cervix is a dynamic organ in the body. It keeps on changing in a different phase of life, from puberty to she's a young, then she becomes puberty, then reproductive, menopause. So it keeps on changing. It also changes according to the menstrual cycle and the hormonal status and ocipil. So what is happening? There is wear and tear on the cervix. So when there is wear and tear of the cervix, this virus goes down in the basal layer and it gets into the cells. What is happening in the cells? It gets the part of the what we can say, the DNA of the cell. So it becomes the part of your own body and it stays there. And what happens if 90% of the infection will get cleared, but 20% if your immunity is low, this virus starts replicating with your own DNA and it produces cancerous cells. So when it is replicating, it produces different type of protein L1 and L2 which are detected, and E6 and E7 which are detected on the later, and then the virus is excreted and it goes from one body to another body. That way it keeps on rotating. Mostly it is considered as sexually transmitted, but that is a myth. There is non-sexual transmission of HPV which occurs from skin to skin contact by fomites. So it can be transmitted by many methods also. Now, this is a current knowledge. What is happening? This virus stays in the cells only. It doesn't cross the basement membrane. It doesn't go in the blood. So, there is no viremia, no inflammatory response, no cytokine is released, and no host cell damage. This escape mechanism have enabled HPV to become one of the most commonest sexually transmitted infection worldwide. Now, this virus goes into the cell, and in the cell, it becomes a part of DNA and it gets excreted. What is happening? The immunity in the body is going to fight and clear the infection. So, it may go in remission, or we can say within 6 to 1 year, or it can remain persistent, and this persistent is the only culprit which develops cancer. So it is like a seed soil nutrient model where HPV is a seed, soil is our own body, and nutrient is our cofactors. So seed, when is put in the soil, it will not grow into the tree. What will happen? It will need water, it will need nutrients. So in the body, what is happening? Cofactors like early marriages, multiple partners, early pregnancy, poor hygiene, smoking, OC pills, STD, HIV, all immune depressed condition, this virus get activators and slowly start growing, and it becomes a tree, it becomes a cancer in your body. So how this HPV is causing cancer? I told you E6 and E7. They are the oncoprotein and they are produced from our own DNA. They get into our DNA and they produce E6, E7. E6 binds and degrades P53, that is a tumor suppression gene, that is a normal mechanism of our body. And E7 binds and degrades retinoblastoma, another tumor suppression gene, and hence the cancer develops. So, for HPV2 cancer develop, two things are important. The persistent infection with high risk type. Not all HPV are going to get cancer. The high risk HPV has to remain persistent for more than 6 months is responsible for developing cancer. And second thing, women having persistent HPV infection for more than 2 years is 300 times to develop cervical cancer. So what is happening when you do a cervical cancer screening is not only enough to have to catch these women, you have to treat them, then only next 10 years you will be preventing them for developing cancer. Now, this is a slide which shows the normal epithelium, the HPV infections, and over the years, it takes 10 to say 15 years from the HPV infection to cancer. And there are many progression. I have susceptible factors, microenvironment factors, genetic factors. All these factors are acting in the women. We don't know which women, which cofactor will work on her. And these are all picked up on pap smear as low-grade lesions, and yet 10 to 15 years this virus in your body, you're totally normal, and yet you women, so many are dying of cervical cancer because there is a lack of awareness, not only in the general people but even the medical faculty. Many of the, I think 90% of the medical faculty, especially if they are not gynec, their wives and never have screening for cervical cancer, which is very much needed. Even the paramedics, even the nursing staff, everybody should have cervical cancer screening. So you see, normal cervix to develop into cancer, 10 to 5, 15 years we have in our body. And if you develop all this pre-cancer condition, it is 100% treatable and cured. So it is our prime responsibility that each and every person, each and every medical faculty should work for it. We should not wait the government to run after us to do something, but we definitely, it is our own duty to be aware and take action. So prevention is always better than cure. Cervical cancer prevention is not a today's program. It is an age-old program starting from 1949. It is now mostly 90 years the cervical cancer screening is going on. It is so effective, the cervical cancer screening, and it is done regularly on organized base in the developed countries like USA, Europe and Australia. Australia is in verge of eliminating cervical cancer in 2020 because of very effective screening and vaccination. So 1949 came the pap smear, then came HPV testing, and now we are into biomarkers and genetics. So there are three pillars for a cervical cancer screening. One is the primary prevention, that is education, awareness is required, and there are certain things as a cofactor which we can prevent, that is late marriage, distance between the two pregnancies, condom use, limit numbers of partners, but that are not in our hand. That is a personal choice of a person. Primary prevention, the most effective is HPV vaccination, and the pap smear screening and the cervical cancer screening comes in the secondary prevention, where we identify either the lesion or the HPV virus and treat them. And tertiary prevention is that treating the cancer itself. Even if you diagnose early, it is nearly 80% cure. So screening for cervical cancer, there are three methods. One is pap smear, which all we know, that is conventional or liquid based. Visual inspection of cervix, which were used as alternative. Now things are becoming, it should be absolute because the world is progressing so fast. We should definitely go for more advanced test. HPV DNA test, HPV self-test kits are available, and colposcopy. Colposcopy is an instrument which I'll be discussing later why we do it, and it is must for each and every patient once diagnosed positive with the screening of cervical cancer. There are three approved cervical cancer screening and the future test: visual inspections, then cytology and molecular. The HPV testing comes under the heading of molecular testing. Now, whenever you are talking about any screening test, there are certain basics we have to know. What is the sensitivity? That is the identifying a patient with a disease. Specificity is identifying a patient without disease. A test which is more specific is more good. And sensitive is also, a test has to be sensitive and specificity, but all things are not available together. True positive, a person having a disease and a test detects positive, and true negatives is a person who doesn't have a disease and the test is negative. Now coming to pap smear. This again credit goes to Mr. George Nikolaos Papanikolaou. He was a Greek physician and he was studying something rats, and he found abnormal cells, and that way the pap smear was invented. It was invented in 1943, and regularly the developed countries are using pap smear routinely for screening cervical cancer. Pap smear has been the most successful strategies for prevention of cervical cancer. In America, the cervical cancer from second has come to ninth because of very effective screening since last 50 years. Australia in the verge of elimination of cervical cancer. The purpose of cervical cancer screening is early detection, treatment of pre-cancer condition and cancer itself. Pap smear is a study of cell exfoliated from the cervix. So these are the squamous cells which are seen on the smear, and these are the normal, which are large cytoplasm, small nucleus, pycnotic. But if there are dysplastic cells, you see there is a huge nucleus, less cytoplasm, and depending upon their configuration, it is again identify whether these are low grade or high grade. These are endocervical cells. So all these are seen on the pap smear, and this is the method how the pap smear is taken. The cervix is exposed and a small brush is put in the cervix, and these all are OPD procedures. Even a nursing trained, especially in developed countries, a trained nurse can also do a pap smear. It's that easy. You have to rotate it and the cells come on the brush and then it is taken for the examination. How is this pap smear done? A speculum is put in the vagina, the cervix is exposed, and you take the cells. Now, there are two methods again. The slide method, where the specimen is spread on the slide and then it is fixed and seen in the under the microscope. The two methods of pap test, one is the regular pap test, that is conventional slide method. It is obsolete in many countries, but in our country and in developing country, it is still a choice in most of the government colleges and in many places in India, because it is cheaper, and liquid based cytology, where the brush is put in a liquid base and then a slide is made. Now these are the two methods. A smear is spread on the slide, brush is discarded and it is dried and then seen in the microscope. In this, the brush is put in a beaker. The cells are in the beaker, and from that cells a slide is made. Now, difference is, you see in the conventional slide method, there is lots of congestion of smell cells, and there is blood and mucus, and there is sometimes, covering of the cells, and it's difficult to interpret. While in a liquid base, you get very clear field, the cells are very nicely seen. So, what are the prerequisite of pap smear? All women between the age 21 to 65, women should not be pregnant, do not do 3 months after the delivery, should not be taken during menstruation, no infection, no vaginal cream, and no intercourse before 24 hours. Now, the reporting of the cytology is known as Bethesda system, and they have the different reporting of the abnormal cells, and this is uniform all over the world. They have to follow this system. So, since the cervix has two different cells, epithelial cells and the glandular cells, epithelial cells negative, that is known as nil. Ascus is atypical cells of undetermined significance. Ascus S is atypical cells with high grade lesions. LCL is low grade squamous intraepithelial lesion. HCL is high grade squamous intraepithelial lesions. And SCC is squamous cell carcinoma. On the other hand, the glandular cells are endocervical cells of the cervix. They are agus, that is atypical glandular cells. Agus FN, that is favoring neoplasia. AIS, that is endocervical adenocarcinoma in situ. Endometrial cells in more than 40 years, then you have to think about adenocarcinoma or endometrial carcinomas. So this is the slide which I said. These are the virus infection and what changes it occurs. When it is occurring in the lower part of the basement membrane, they are picked up as a low-grade lesions. When it is occurring in the whole length of the basement cervical epithelium, then it becomes a high-grade lesions. And when it is perforated going in the basement membrane below the membrane, then it becomes the basal layer carcinoma in situ or invasive malignancy. So the screening guidelines, what is the screening guidelines? Below 21 years, there is no need of screening because women's immunity is very good. So the screening is not recommended. 20 to 14, 29, cytology alone every 3 yearly. And above 30 to 65, cytology alone, or you can add HPV. By adding HPV, what is happening, you can do it every 5 yearly. Even after hysterectomy, the screening is not required because uh, the incidence of scene 2 in, if a woman is not having any cervical cancer, the incidence of cancer is very less. And in HIV positive, you have to do annual screening if you are doing pap smear. And even if you are vaccinated, you have to do screening of cervical cancer. It doesn't mean that you have taken HPV vaccine, there is no need of screening. Coming to visual inspections after application of cervix, that is to see the cervix applying certain solution, that is acetic acid and lugosiodine. This is an alternative method to pap smear, and this was developed because of the country like us, developing countries in rural areas where we don't have the facility of lab, we don't have cytopathologists, because to report pap smear, you have to have oncopathologists specially trained in this subject, and it takes long of training. So these methods were developed. It was a single visit and treat method, instant result, good sensitivity, and it doesn't require any sources, no laboratory required. What you required is acetic acid, a speculum, and you need to apply on the cervix. And the squamous dysplastic cells will appear white because of the coagulation of epithelial protein, and this way you can identify the abnormal cells. These are the WHO chart available where a doctor can keep in her clinic, and she can check. You know, if this patient is not going to come back to you again, then you can apply acetic acid. You can see on the cell white patches. You know, these are pre-invasive condition. Definitely they need treatment. And how does a Willy work? Willy is Lugol's applying Lugol's iodine. The squamous epithelium contains glycogen, which will stain brown. You see the cervix looks brown. But if there are pre-invasive lesions, they will not take they have no glycogen, so they will remain yellow. So you can see all these yellow patches. So when you apply Willy, you can see abnormal areas, and these women are having pre-invasive condition. If you treat them, that definitely you will prevent from developing cancer. These are all alternative methods developed in a rural setting for doing large scale screening. Now coming to HPV DNA testing, which is a new test for cervical cancer, which is a molecular test. Now this I want to always like to highlight when I'm taking a lecture, that we Indians, we believe that we are poor in screening, we are not good in record keeping, but this data we are proud that we give to the world. HPV screening for cervical cancer in rural India. This was done by Dr. Rangaswamy Sankar Narayan. He was the chief of Cancer Screening Group, International Agency of Research and Cancer. He was in WHO, and he did this study. The study was a longitudinal study conducted in 500 villages in Bombay, Maharashtra, and it was comparing VIA, pap smear, and VIM, that is visual inspection, HPV, and 130,000 women between the age 30 to 50 were screened, and they were randomly divided into three groups. What they found out that HPV screened rooted out more cancer and prevented more death. That was the basic why HPV should now be used, because it prevented more death than other screening tests, and with very few false negative rate. So HPV group only 8 patients developed cancer compared to other group, and this is the reason why HPV has taken over pap smear. In addition, HPV and pap smear group, 60% cancer were detected early in stage 1 development compared to VIA group. So in conclusion, in a low resource setting, a single round of HPV test will be associated with significant reduction in number of advanced cervical cancer and death from cervical cancer. So HPV test using as a screening, as a primary stage, what are the benefits? It is a more sensitive and a highest negative predictive value, and the risk for developing CIN3 lesion after negative HPV test is zero, nearly zero after 5 years. So it is so specific. So that is the reason why HPV is testing should be used. This characteristic of HPV testing could permit longer screening intervals and lesser screening visit for the women for the lifetime. For India, what is happening? What difficulty to get a women? We don't have a organized screening protocols. So women has to come again, which is not at all possible. So HPV test is definitely very good for developing and underdeveloped countries where we are not going to get all the women for screening. So there is a pedigree shift. You do HPV primary test and then triage with cytology and do the treatment. Now, which HPV test to do? Because it's a virus, so virus is, there are DNA based molecular test and there is RNA based molecular test of HPV, and the most recommended test is doing for screening is HPV DNA test. Now coming to details of HPV DNA testing, there are 14 carcinogenic type which I have mentioned earlier. Primary HPV test you have to do when you're doing a standalone, then it has to be an FDA approved. Only certain tests are FDA approved. When you're doing a co-test, you want to do HPV and you want to do pap smear also. At the same time, that also can be done. And only certain tests are what we can say uh, approved for doing co-testing. So when you are testing the DNA, RNA, what is the difference? See, when you are doing a DNA testing, you are targeting the genome, and while RNA, you are targeting the oncoproteins. So the detection is higher with DNA, but the RNA detects the active infection. The DNA testing can detect the transient infection, while the RNA testing focuses on the active infection, which will lead to cancer. It detects all HPV infection in DNA testing. In RNA, it only detects the progression of risk. So DNA can be used for screening and early detection, but RNA, we can't use RNA because it should be used as a triage or follow-up for abnormal cells. So the WHO recommendation is, if you are using for primary screening, it has to be HPV DNA test, and there are the WHO guidelines to screen and treat or screen, triage and treat, where HPV DNA tests are used. RNA can use as a co-test in, especially in screen, triage and treat. It is recommended for HPV DNA is recommended as a preferred primary screening test, but no recommendation for HPV RNA test. If you are doing HPV DNA test, then the screening every 5 yearly or 10 yearly. Imagine if you have to come only for 10 years, only 2 times to do cervical cancer screening. Then I don't. It's so nice. It's so effective. You only have to bother 2 times. You don't have to go yearly and 2 yearly. And HPV DNA test, the benefit, it can be used as a self-test, but RNA you can't use as a self-test. So there are very different type of assays are there to detect HPV testing. That is DNA screening assays, that hybrid capture. This screening method is used for co-testing. Then DNA screening assay test, that they detects HPV 16, that is invader chemistry. This is all what we can say science behind the test, which we need not go in detail. But HPV DNA testing, genotyping testing, where we are detecting the virus, that only can be used as a primary test. These above two are used as a co-test. That is, you have to use it with pap smear. That is done with the PCR machine. And that HPV 6 E6 and E7, that is RNA test, where it is using the transcript amplifier E6, E7 on the HPV virus. So these are the different tests, and they are approved with the code. First and second are used as a co-test. Third, genotyping can use as a primary test and also can be used as a co-test. E6 and E7 is a test which is specific, and it says the presence of true disease is an aptema test, and it has to be as a triage test rather than a primary test. So these are the different companies are there where they are doing the HPV genotyping testing. And these are the various what we can category, whether these are partial genotyping or there is a complete genotyping, which I'll be describing in my few slides. These are the FDA approved tests for primary screening. These are many tests are now at present we have 40 tests of HPV screening, and new tests are coming every time in the market. But these are till date FDA approved, that is Abbott, BD and molecular Ross system. Again, in HPV DNA test, there are two types. One is closed system and an open system. In closed system, the whole machine and the test and the reagent, everything is approved, validated. While in open system, the only the reagents are validated, so that can be used in different PCR machines. So there are different methods also validation. It's a big topic itself, that validation has many criteria. How do you validate HPV test? Now you see this genotyping. There are 33 genome which are being detected while testing. While if you see in the COBAS, it is a 3 result run. That is a partial genotyping. What they do in that, they'll tell whether it's 16 positive, 18 positive, and whole other viruses come in one basket. Other viruses, it may be positive, it may be 1 or 2 or 3, but comes in one, but it's partial genotyping. But if you go for other decode type life sciences, what is they are doing, they will tell you which virus is also positive. So what is happening, the more you go for run, more you go for detection of virus, the costlier the test will be. So sometimes it is not definitely going to help in the clinical practice. So partial genotyping is enough for doing a primary screening, where you can know 16 and 18 other viruses. That is enough for screening. You need not go for the detail for each and every virus, because it doesn't di- uh, difference in the management of the patient. Even if you are having other viruses, and in the number doesn't matter. The treatment, the clinical application treatment remains the same. So HPV stand alone. or co-testing, which is benefit. You do HPV testing alone or you do a co-testing. This was a huge trial done by USA Casier Premanat study, and they have screened around 3 lakh women, and they concluded that negative HPV test was enough assurance for low risk in 3 and invasive disease. Additional pap test did not give any provided extra benefit, hence HPV alone can be used for screening. So WHO recommendation is for general population screening, HPV DNA testing is recommended as a primary screen and treat or screen triage or treat. For population with HIV, you need to have HPV DNA test only. You cannot do HPV RNA test because the studies are not available. Now coming to HPV self-test. Why this self-test came? Because this was a virus, and what happened during COVID, everything was shut down. The whole world was shut down. So the screening, women were not coming for screening, and the health workers they became very, what we can say, anxious. How do we promote screening? And this self-test that time came into existence, and it was been studied since long because it is one of the very good method a women can do at her place, at her convenience. In Europe, you get the sample in the letter, in a post, you do the test and send them back. So that is that easy. So the self test. New tests are coming, that is point of care, where a small slide is there like a pregnancy test. You put a specimen and you get whether it is positive, negative. Here you don't get the genotype, only you get that you are infected or not. Now why these things are coming? Because the limitation of cost, processing, laboratory infrastructure, and especially in countries, low middle income countries and HIV population, where you need to do again and again screening, this all tests will be very helpful. Now this was a last year a paper which has come in the European journal from the Europe U screen, and they said that offering self-testing to non-attenders with people who are not very pragmatic, or we can say who are not very liable for screening, who are not uh, who are not undeserved, or we can say potentially unreachable, the providing self testing is very viable start, and it is feasible for the long run for screening protocols. And they came out the interpretation that offering self test to under screened women in a primary care could increase coverage in England and potentially reach the underserved population. Now HPV testing is also done from menstrual blood and urine, but still they are not validated to use as a primary screening test. It can be used as a test to screen HPV in, if a woman comes walking and you want to do, you can use it, but you cannot use as a primary screening for general population or organized based screening. In future, what we have in our basket for HPV testing is DNA methylation. DNA methylation changes are seen in HPV genome, and by detecting them, you are detecting the precancerous lesions, and you can target the treatment. Oncoprotein biomarkers, that is HPV oncoproteins, that is what I said, E6 and E7 antibodies, HPV DNA, these are all specific protein like P16, Inca 4A. These are all protein markers which are studies when there is a infection in the cervix, and which is a pre-cancer condition. The HPV infection has converted into cancer. These all biomarkers will help. Now why this all things have come up? Because what is happening, women are getting job oriented, they are delaying their marriage, they are delaying their pregnancy. So sometime at the age of 30 they come with such type of infection, they don't want their uterus to remove. So usually people go and get their uteruses removed, or they don't want follow up, they don't want any surgery in their body, they don't want biopsies. So whether this HPV infection is a pre-cancer condition or it is a transient infection, so these all tests in future will be very helpful, and even helpful today. So these are the dual staining. This is a test which is routinely done, that is P16 Ki16. It is a IHC staining which is done in the cytology for detecting scene 2 scene 3 lesion. If you have a scene 2, whether this is a high grade lesion or a low grade, CSP16 CKI16 definitely help. P16 is often used as a surrogate marker for HPV infection, and it is a potential indication for cell deregulation and progression cancer. And Ki16 differentiate between the benign and dysplastic lesion. So coming to the different screening approach, every screening approach is good. Not a single woman from your clinic should be walked out before doing a cervical cancer screening. Cervical cancer screening, there are different methods, VIA, pap smear, and HPV. Everyone has his own benefit and limitation. VIA Willy are very good simple method and can be done in the rural area, PHC and CHC, but the specificity is low. Pap smear is a good test, but you have to have recall because it is less sensitive. It is, you have to have call recall method. Women has to come again and again. HPV is very good, but it will, you don't know which HPV infection is a transient or is an actual infection. And there are non-related HPV carcinoma which can be missed by doing simple HPV tests. But still, if you see the sensitivity, specificity, HPV stands the highest and it is better testing. There is a new test which is DNA ploidy test where it measures the cell aneuploidy. Whenever there is a dysplastic cell, the chromosome, there is aneuploidy cell, which is the number of abnormal DNA, which is picked by AI, and they do the DNA ploidy test. The sensitivity and specificity are very good, and this is developed by British Columbia Cancer Research. And you can see there is a pap smear. These are all dysplastic cells, whether these are transient infection or they will regress. Whether this infection seen one is going to develop or it's going to regress, we don't know. But the DNA ploidy will definitely say they are a chromosomal abnormality. Hence, this lesion is not going to regress. Definitely you have to treatment. This is the reporting structure of the DNA ploidy report. Many new things are coming. This was discussed in large HPV conclave where the AI-based screening methods are coming and which can be done in the rural or large-scale screening method. Now, what are the WHO guidelines for screening for cervical cancer? The new recommendation are that WHO recommends using HPV DNA detection as a primary screening test rather than VIA cytology in screening and treatment approaches among the general population of women and women living with HIV. The starting age of screening should be 30 years, but for HIV is 25. Criteria to stop is 50 years. 50 years doesn't mean that a woman coming at 50 years, there is no need of screening. In our India, a woman entering in your clinic has never had a pap smear or HPV in their life. So even if women coming at 60, 65, 50, if she had never, you have to screen those women. You just cannot let them go. Frequency is 5 to 10 years in general population for HPV and 3 to 5 years for HIV. If you have taken vaccinated, you definitely have to screen this women. You can, because vaccine are only covering certain screen, they are only 9-valent. If you're taking nanovalent, it is 9 viruses covered. If you're taking quadrivalent, it is only 4 viruses covered. There are other viruses, so you have to undergo screening. If HPV DNA is not optional, you don't have the facility, especially in rural areas or underdeveloped countries, then cytology and VIA are a good alternative. These are ASCCP guidelines that primary HPV testing reflects cytology. Combining to this, both the test has high sensitivity and specificity. These are the comparison of various societies of the world, but if you see, the all remains almost same. And in India, we have FOXY GCPRA guidelines, which I'll be discussing in my later slide. Now, if you have come positive, what does it mean? If HPV is positive, do I have cancer? If pap smear is positive, do I have cancer? What next? This is a biggest question. It is said by only doing screening. Now the screening has just mushrooming everywhere. Oh, HPV, HPV. But what after that? You have to guide this women. We have to pick this women and then treat them. Then only you're going to do any good. Just doing screening is not enough. You have to treat them. What next is a very big question. So there are two different modalities, screen and treat approach, where a primary screening is done and you treat all these women with HPV positive. Screen triage and approach, where the HPV DNA testing is done, and if they're positive, you do a cytology or a colposcopy and then treat the women. So these are WHO guidelines and these are the clinical pathway which are available, everything on the net. And a WHO screen and triage method, you triage with HPV genotyping. If you have done a simple HPV, then you do with the genotyping, find out whether high risk or low risk. If there is a colposcopy triaging, then you do with a colposcopy. If the VIA, then do with VIA with cytology. So these are the different methods. Now coming to colposcopy, what is a colposcope? Colposcope is a microscope where it is magnified view of the cervix, and the things remain the same. You have to look into the cervix and find out the abnormal areas, because all these changes are not visible to the naked eye. They are occurring in the cells. So what is the basic of colposcopy? This is a squamous epithelium of the cervix. They have small nucleus and big cytoplasm. So when acetic acid is applied, the light passes through it and it is a pink area. But when there are dysplastic cells, abnormal cells, chromosomes are there, and you see there's a huge, thick mucus, what we can say, sorry, nucleus. And when acetic acid is applied, there is a coagulation of protein, and the life uh, reflects, and it gives a aceto-white appearance. So the basic of colposcopy is abnormal white areas. You apply green filter and you see abnormal vessels, that will help to identify the grade of lesion, and apply iodine and Lugol's iodine, which will tell you what is the abnormal area. The transmission zone is very important, and this is the zone where all these changes occur. I am not going in discuss. We'll keep another lecture for colposcopy. There are various type of transmission zone, and the treatment depends upon this transmission zone. These are low grade lesion. You see mild cytovite areas, and these are high grade lesion. You can see mosaic punctations, and you need to have very extensive treatment for this type of lesions. There is a scoring of colposcopy. If you're a beginner, you can put all your data and you get a score, and from the score you can come to know whether it is a low grade lesion or a high grade lesion. This is a reporting. My colposcopy, which is a AI based, it also gives you, AI also will give you whether it is a normal sin 1 or sin 2, and it is a scoring of the switch score. After doing a colposcopy, if you find a small lesion, you can do a cryotherapy, you burn it, and if there are huge lesion, you have to do a cautery. This is a lip biopsy where you do it, where with a small biopsy you can remove the lesion and the treatment is over. You see, the treatment is complete. To remove the lesion, the treatment is complete. So cervical cancer is 100% curable if they are detected in pre-invasive condition, and once the cancer develops, the survival follows. So what is the role of colposcopy? Colposcopy is must in all the patient of positive report, and the colposcopy is the modality where you have to follow this patient and treat them. Colposcopy doesn't mean to see images of the cervix, but it is a process to see the changes, watching the cervix over the time, real time. It's like a movie. The primary goal of everything is prevention of cervical cancer. The colposcope was invented by Hilsman. So he said the man who thinks cytology is better than colposcope. That time we had cytology, no HPV. So he said the cytology is better than colposcopy, or colposcopy is better than cytology, is a fool. He doesn't know anything of either. So both are complementary and both are needed to treat the patient of cervical cancer and prevention. We say cytology HPV identifies the crime, while colposcopy locates the culprit. Colposcopy sees what a normal eye cannot see. This is a wonderful book by Dr. Sankar Narayan, Colposcopy. It is available on WHO website. It is a very good book. It is a Bible for colposcopy. These are the normal cervix, and what we get are these cervix. You can see this takes 15 years to develop. Why we get a women in this type of cervix? It's because we are not aware and there is no screening. You see, if a woman is picked up in early pre-invasive condition, the treatment is ablation, cryotherapy, hysterectomy, and look the cost. These are the cost in the private hospital. It is a very treatment is easy. In a government it is free. For cervical cancer, you need a specialist like me, the radical surgery, and what is the cost? 3 to 5 lakh rupees. I think we all should now get aware, and it is our duty that we do cervical cancer screening and we motivate women and do. The reality in India is it is prevented but not prevented, because our country is a very diverse country, huge population. From east to west, you see there is a cultural difference, a language difference, and we have state of art hospital, a robotic hospital, robots in the metropole cities and metros and everything. In rural area we don't have a simple lab, no microscope. So our countries are diverse in economy and everything. No uniform screening strategy, and lack of the human resources, and this is the reason why women so much are dying for cervical cancer. Now look into our women population, 16 to 15 years, 44 crore women. We are like a small country in our country. Women are a country in our country, so huge population to cater. And if you see the 14 years, the age group where vaccination, that is 10 crore. So we have huge people to cater in our country. If you see the vaccination is 0.9%, testing is 7%. How it is going to possible to screen all these women? We all have to become aware and spread awareness. This is the Foxy guideline, GCPR for Indian population. Same way, see and treat and screen and treat. This is for colposcopy clinic. This is for health workers who are in the rural areas, where they can do a VIA, detect the abnormal area and treat them. And these are the source dependent screening tool. If you are in the corporate hospital, you can do a primary HPV testing. But if you are in a rural area, a government setting where you don't have this facility, you go for VIA. Age group is same, but our India, what we have, early marriages, early pregnancy to age is 25 and up to 65. Doesn't mean after 65 you should stop. If a woman has never screened her life, even at the age of 65 you have to do screening. And the frequency and same remains same as international guidelines. And when, so which test to do? We cervical cancer screening is like a cafeteria. Whatever you have, you can do it. You can do a VIA. Will is not difficult to learn for as a gynec. Pap smear, HPV, ploidy, and colposcopy. And you should know all this method, that what you are seeing. By Willy, you are seeing the abnormal area. By pap smear, you are detecting the abnormal cell. HPV, you are detecting the virus. Ploidy, you are detecting the cancerous cell. If you are doing the dual testing or Aptima test of HPV, you are detecting the preconditions of the cancer. And by doing what we can say colposcopy, you are identifying the abnormal area and treat. This was the historic movement, 2017, a historic movement for global health. It marks the first time the world has committed to eliminating a cervical cancer. This was done on 17th November 2020, pre-COVID. Dr. Tedros Adhanom, WHO director then, and they came with our vision, WHO vision, a world without cervical cancer, to bring down the cervical cancer to very low level. And this can be only achieved by 90% girls vaccinated, 70% women screened by the age of 30 and 40, and 30% reduction in cancer treatment mortality. That was the target which was developed for 2030, achieving the elimination of cervical cancer, that is 90, 70, 90. If you see, the vaccination today in India is 0.1%, screening is 7%, 70% screening. How it is possible? Each and every woman should, even as a citizen of India, we have to have our own moral responsibility, that I should screen my mother, my sister, my friends. I should promote each and every woman in contact with me for screening. Then only we'll achieve this target and 90% treatment of cervical cancer. Cervical cancer strikes women in a prime of a life. These women are raising children, caring for their families, and contributing the social and economic fabric of their communities. If we don't act, death from cervical cancer will rise globally. But it doesn't have to be this way. It has a ripple effect, which I said in my first slide, that a woman at the age of 40, she is a teacher, she is a principal, she is a caretaker, she is a mother, she is an income earner, she is and the peak of her career. And that time a woman dies of cervical cancer is a big bad, boost, what we can say, bad setback to the country, because a person to develop to that level, it takes 20, 30 years of your career to develop at the highest level of the strategy of the community. And then the person dies, you're losing so much income, you're losing a very wonderful person from a life, which will give so much to our country and to the economic development for the society. So cervical cancer, it is said 24 years of the life is lost if a woman dies because of the cervical cancer. And above it, the psychological impact on trauma is very big thing. And these are the areas which are never been answered or never been said. This was the thing I calculated. If a woman is going for HPV testing in private sector, it is around 3,000. So in 10 years only she has to spend 6,000 rupees. But look into the cervical cancer. If she's for 10 years, it is around 4 to, this is the older, but I think so now it will be 3 to 4 lakh rupees. If you are doing 100 women, 60,000, and you lose 100 women, the cancer treatment goes in crores and crores. This is all money which has been wasted, and with the patient's relative, patient husband, everybody are after them, and you all lose. We are losing so many man hours also because of the cervical cancer. My mission is HPV awareness, testing, and HPV vaccination. This is the first HPV clinic. This is Mr. Som Pathak. He has invented this HPV what colposcopy device under the WHO scientists, and it was first launched in India in my clinic. And this is the EI based colpos. It's very easy to get. Even the nursing staff can be, the main aim is that nursing staff can do the colposcopy, and the system is, the reports are on the cloud, and I can be sitting anywhere and I can report them. And this is Dr. Walter, who has invented the lip biopsy, and he visited my clinic. And I have done the first HPV self test in Gujarat, and this is the way the self test is done, and is very easy method. And this was the first HPV self test taken by my friend. And this is the flyer which I have made for the doctors, even to the patient, to understand how to do the test, how to open the wrapper, how to put the swab in the vagina. And I presented my data also in the conference in the Bhubaneswar. So cervical cancer is not a single word. It is a spectrum of things, from pap smear, Eschers, Elgel, scene 1, scene 2, colposcopy, early detection, treatment, lip biopsy. It is a whole big basket. And all things you should know, then only you can do something for cervical cancer prevention. Cervical cancer prevention strategy to reach for elimination. What we have to act now is vaccinate all girls and screening, cervical cancer screening from the age of 30 to 65. And this was the Eurogen conference which I went in 2023. There was an HPV conclave, 7 days HPV conference, and it was 7 halls. I went then, I realized in India, we are 50 years back, we only know the word of HPV. There are lots of research and everything are going on HPV. And this is my very good flyer where I have written everything. Cancer awareness, we have to protect our girls by vaccinating them. Mothers should get tested, girls should get vaccinated. We should not even forget our boys, because HPV even affects them. So you imagine a normal cervix to develop cancer 10 15 years, catch all the women's, tell them to get vaccinated. Even if you are young, you yourself as a man boys get vaccinated, and each and every woman should be screened for cervical cancer. Not a single woman should die of cervical cancer. And how we can prevent HPV is by getting vaccination, by educating awareness. And I do lots of awareness talks everywhere, and I go and spread awareness. I do talks on TV, I do talks on even social media, only to bring awareness and screening for women, to encourage them to go for cervical cancer screening. So this is one of the slide which I put on my social media. For every 100 women dying of cervical cancer, 4 children will die before the age of 10 because of the loss of mother. And this was my trip to Mongolia, where a colposcopy, I said no, they had taken me there. They are doing in Mongolia colposcopy as a primary screen, and I went there for the visit. And it was a definitely very interesting. They had done around 25,000 colposcopy screening for each and every woman, and it was a very good experience with them. To conclude, cervical cancer is a preventable cancer. HPV infection, a very common infection, affects both women and men. It causes spectrum of disease from warts, pre-invasive to cancer. Persistent high risk infection with HPV oncogenic type is a cause for cervical cancer. Pap smear is a gold standard, time tested for cervical cancer screening, and it can be done if you don't have the facility. HPV testing is promising and should be used as a primary test for cervical cancer. HPV self test is a vital role because it enhances accessibility of test, especially in country like India, because women handling children, they have to go to the hospital, they have to go to the job, and you go for the hospital, you have to go for the parking, and then parking problem, then you go to the hospital, there's a line in the hospital for a simple test. It is a 3 to 4 hour job. So if you have a self test, you can do it at your home at your convenience, and you can do a cervical cancer screening. That is very important. Self test is going to be a game changer for a country like us. All women who are screen positive must be treated and put under surveillance. You have to catch all these women and treat them. And HPV vaccinated women also has to get screened for cervical cancer. So my take home message: for every woman, HPV test is must. For every girls and boy, HPV vaccination is must. Thank you very much. Screenings definitely save lives. And if you have any query, you can call me. I'm always available on my phone. Thank you very much.